Medicine in the Division of Cardiology, and he's going to tell us today some of the stuff that he's been up to recently. So, Mike.
Great. Yeah, the 12 is the 7 in homage to John Elway. Is that a 1207? So I wanted to throw this up here. I'm going to mention this a couple times. This is our website that we built that kind of describes this whole process, because I'm going to try to go over this as best as I can, but some of the details tend to get washed over, and when I've given this talk similarly, I think people have different questions if they missed something that maybe I might not have appreciated was a key part of it. But if you go to our website, not only does it have analytical approaches and Python code and R code and things like that, but we also have just descriptions of the different components and a sort of 5-part series and stuff. So I'll mention it again, but if there's stuff from here and it didn't feel like it was answered, you probably will find the answer on the website. These are my disclosures. So I always love this quote from Wayne Gretzky. Sort of people ask him, why were you so great? He said, I skate to where the puck is going to be, not where it has been. And I think that's pretty relevant for what I'm going to talk about today, because I don't have great examples of this process being applied today in the way we practice medicine. But I think that this is the place that things are going and the direction things are going, certainly with the increasing technologies and things that I'll describe today. This was actually, I actually found this when I give a talk. It's amazing that this was 10 years ago, but this was from Nature, and essentially what they were trying to describe here was this gap that had formed between clinical practice and basic science, and it was sort of this need for translational researchers. But more recently, I've kind of come to think of this as more relevant for today as kind of this chasm that we're sort of facing, as we have kind of the past of both clinical and research, where it was based on empiricism and paternalism and kind of one person's sort of interpretation of what's going on, and a move to using technologies, using data, using informatics to make those decisions, and whether this is going to be whether this is a cliff that certain people are going to fall off or not, hopefully won't be the case. But I do think we're sort of reaching a point where we're making this transition, willingly or unwillingly. There are definitely people who don't believe in the idea of, or I shouldn't say don't believe in it, but are skeptical about the quantitative approaches. Bruce Spiegelman's a well-known biologist who was at Harvard, who basically would tell people in his lab, if it requires statistics to show it, I don't believe it. Obviously, we know Benjamin Disraeli, the 3 types of lies, damn lies, and statistics. And Mark Twain, everyone's favorite, figures don't lie, but liars can figure. The rally being that, when you're relying on numbers, when it's something that's not in front of you, it's much more difficult. There is kind of a leap of faith involved. But yet, all over the world, this is happening. Moneyball, this book came out 15 years ago based on the idea of applying sports analytics to scouting baseball. And I found a lot of parallels between this and sort of what's happening in clinical medicine, where, you have the numbers geeks coming along, saying, this guy is, batting average, or he hits, a certain amount in such a situation, and then the scouts say, no, you got to trust my clinical judgment. I've been doing this for 50 years, and I can see talent, and I think at this point we've come to learn that you need both, but you do need the numbers as well. And teams that use that tend to do much better in the competitive realm. It's also tells you they've already made a movie with Brad Pitt about it, so it's been out. Nowadays, there's sports analytics conferences. ESPN is buying a website that's based on analytics. So it's definitely making its way. It's everywhere around us. It hasn't quite made its way into medicine. Most of us, a lot of us are still comfortable with the idea of, I can see these blots, on a frame. I don't need the statistics to show me what's up or down. But then even in the basic labs, you're being asked, well, how do you interpret this? Or how do you put it into one of these cluster diagrams, or put it into a genetic plot? Kaplan-Meier curves, forest plots with meta-analysis. Numbers are really everywhere in what we're doing clinically. But I think as I'm going to hopefully go through, how we use those makes a difference. So I'm kind of going to just take us back a little bit because I don't think that this is something that's happening suddenly. I think that a lot of what's happened over the last 100, 150 years in medicine has kind of brought us to this point. This is a great slide if you're a Bayesian. I don't know people here who really engage actively in the frequentist versus Bayesian debates, but clearly the Bayesians are on the other side of the Homo sapiens. The frequentists haven't quite made it to Homo sapiens, so kind of a stats nerd joke for you. Most people don't necessarily know who Leonard Thompson is, but he was the 14-year-old that was the first person cured by insulin. This is work from Frederick Banting and John MacLeod. They were at the University of Toronto. They didn't discover insulin, but they were the first ones to really isolate it, first from a dog and then from a cow. They won the Nobel Prize. They didn't need statistics, right? I mean, these people got better right away. There's actually a story when they started giving it in one of the intensive care units, how by the time they got to the end, all the people who were like on their deathbeds at the beginning of the administration were getting up and walking out. The effects were dramatic. You didn't need statistics to show you that it was working. It was the same thing with Alexander Fleming. Most people know who he is. He was the sort of not the greatest lab hygiene, when it came to bacteriology. Went on vacation, left a bunch of his petri dishes out, got back. One of them had gotten contaminated with penicillium. Most of us know the story. Noticed that it was killing off a lot of the staph colonies. What's kind of interesting about this story is that this was not really well recognized at the time, at least at that time, as a big discovery. It was published in the British Journal of Experimental Pathology, which I sort of would equate to if you would have discovered the cure for AFib and then have to publish it in like Europace. So it's eventually people realized, that you could turn this into a medication called penicillin. It could be used to treat infections. This was medical empiricism. These people just got better. Again, we didn't need randomized control studies. We didn't need statistics. Someone was deathly ill with an infection. You gave them penicillin and they got better. So, things started, I think that the thought process was starting to evolve. I don't know how many people know who Jon Snow is. Most people think of Jon Snow as the, rightful, leader of the Seven Kingdoms, the Lord of the Night's Watch. But actually, this Jon Snow, probably more important, was around in the cholera outbreak in 1854 in London. And what he did was really interesting. He basically mapped all of the cases and was able to pinpoint it to a pump on Broad Street, which the lore is that he went down there and removed the pump handle. I think people later, he himself admitted that he just told them, why don't we shut this off? And it actually turned out that people were already getting, or the people that had gotten it were already dying and they were turning around. So he was very much modest in the effects. But the whole idea is that this was, he was taking a systematic approach to disease, and we, credit him as sort of the father of modern epidemiology. He was using kind of a scientific process rather than just, rote empiricism with treating patients. But I think in a lot of ways, the person who really has brought us up to this idea of using data, using evidence, was Archie Cochrane. This is an amazing story that he told in 1984. He was, know him. He was a Scottish physician who was went into the army and then was captured and taken to Greece, where he was in a prisoner's camp, and he noticed that people were getting leg edema, which he hypothesized was due to malnutrition. We now think of as wet beriberi. But he decided, rather than just kind of, treating, probably empiricism, he said, I recruited 20 patients. I gave them a short talk about my medical hero, James Lind. They agreed to cooperate and experiment. I cleared 2 wards. I numbered 20 prisoners off, odd numbers to one ward, even to the others. Each man received 2 spoonfuls of yeast daily. One group got the vitamin C. He actually stole this on the black market, the placebo. The other got yeast, which contained, the nutrients they thought were important. He then separated them. The orderlies cooperated. They managed their, measured urine outtake. After 2 days, there was no difference, but by the 3rd and the 4th, it was inconclusive. There was conclusive. There was less edema in the yeast ward. Presented his findings to the guards, and they actually started to give the prisoners yeast to try to prevent this edema. So he calls this his first and worst clinical trial, but really this was the start of using randomized controlled trials to look for evidence that we're not just going to trust we give this person something and they get better. I think it's always funny to think about the role of statistics in just health in general. This was a pamphlet that was released in 1968 about smoking. At the time, they were starting to do studies to show that there was a link with cancer. This was the counter argument to that, was like, well, statistics alone links cigarette smoking with cancer. So it's like, who are you going to trust, statistics or your smoking grandma who's 90 years old? It was really kind of a appeal to that. It also didn't help that doctors were recruited to help represent the cigarette companies. But everyone sort of has, I think a lot of fields will have their example of when did we really realize that we needed evidence-based medicine. And I think within EP, most of us, or at least I certainly think of the role of ventricular premature beats and management of those is really the point where we realize that maybe we need to be studying this stuff closely. It's pretty interesting. I trained in Boston and everything, so they would tell you these stories. If you trained at the Brigham and Women's Hospital in the 1980s and 90s, with the Lown group, you were taught that there's a whole classification for premature beats, and that people, using, again, empiricism, they were saying like these beats are linked to a certain risk. This type of characteristic is really high risk for sudden death. These ones are lower risk. There was a whole science behind this. There were studies showing that premature beats were linked to risk of sudden cardiac death. It was seemed like a nice causal pathway. So then they decided to study it, and they did the CAST study and basically showed that it was the opposite of what we thought, that the medications we thought were preventing the thing that was causing the problem were actually causing death, or at least one class of them, the 1Cs. I think today now, you can look no further than I think what a lot of us would consider one of the most successful medications in history, the statins, largest selling drug. Nobody feels better after. Does anyone have a patient that feels better after starting a statin? We only know they work because of statistics and clinical trials. This is we've kind of ventured into the era of quantitative medicine. Guidelines. We don't set guidelines if someone walks up and says, "I just treated 10 patients with this, and they all got better." We require trials. We require evidence. We require statistics. Are we getting to the point where we're just going to be pulling out our computers in clinic? It's hard to say, and I think part of it is because we're not quite there yet. And I think that for one we're kind of halfway there. But I think a good example of why is, if we go to the 4S study, this was a study, as I mentioned, this is one of a lot of studies that showed that there was a benefit of using, on a population level of statins. But if you actually look at, how many people, benefited individually? And to do this, we use something called the number needed to treat. And these are pretty high. They ranges from 50 up to 150 for people. I mean, that basically means that you're treating, so if the number needed to treat is 100, you're going to treat 99 people for no reason who are not going to benefit. It's the population application. This is a great graph because it kind of shows it visually. This is a hypothetical treatment, for some condition that's got a 13% incidence. This would be a New England Journal paper. If you had a treatment, it treated, 3 people, or it saved 3 lives out of 100. This would give you a 70% relative risk. The number needed to treat for this is 33.3. So again, you're treating a lot of people just to get a benefit in one person. This is the state of medicine. We're applying population level thinking to individualized decision making. And that's great if you're into, if your goal is to set guidelines or you want to determine which treatments we should be using. But that's not how we treat patients. Patients don't come into our clinic and we just release the guidelines to them. We want to provide each patient with individualized care. And so really this approach is failing in that sense to really provide them with what we really want, which is a quantitative measure of their own risk. There's all kinds of these great examples of the problems with, applying, average-based thinking, population thinking to individuals. This is great. There's a drunk wandering down a highway. He's wandering back and forth between the lanes. His average position is in the median. So in theory, if he's in his average position, he's safe. But the reality is that by wandering back and forth, he's getting, all of the drunks are getting hit, so the average state is dead. This is the flaw of averages, that the average depth here is 3 feet, but actually in one part of the pool, it's 11 feet. So, I think that this sort of population thinking is is useful, again, for, if you're trying to make a big, statement about the population, but for individuals, it just doesn't work, and certainly the way that we apply it is not working. We want something that works for individuals. So what do I think? So what do I think is the way to do this? Well, I think one way to kind of think about it is to take a step back and think about this sort of Epi 101. So let's say you have some factor that you think is related to a disease. We'll say like smoking and just feeling poorly. So we all kind of know if you want to get a measurement of this, you're not just going to give someone one cigarette and then see how they feel. You need to build some kind of distribution so what's the probability that this person's smoking is actually related, or that there's a correlation that's not just due to chance. So you need to collect a lot of data points. Well, how do we do that now? We go out and we design a study. We go collect data on all these different people who are out there. Some of them smoking, some of them not. Some of them have disease, some of them don't. We form a correlation. We get some effect size. If it reaches a certain significance value, we say there's a correlation, and then we can test later by intervening on that if there's causation. But this isn't really what we want, right? We want to cure this guy here. If this green guy over here, this guy's like eating ice cream, that's not relevant to our patient who's right in front of us. But yet, if we want to, use the current population-based methods, this is how we do it. What's the alternative? Well, actually, we can think about it using our favorite, this is the sort of title, we can go longitudinally, just collect data over time. So we take our same guy, some days he's smoking, some days he's well, some days he's smoking and sick, some days he's not smoking and sick. You can start to build a model around this single individual, their pattern of correlation between smoking and non-smoking by measuring multiple points over time. This is useful for a lot of reasons, not only because you're just measuring that one person, but you're actually, by only measuring one factor in that person, you're actually adjusting for all their other biases that are placed. There's a method called fixed effects models, which is it basically anything that changes in that individual over time will match for itself. So how does this work? How could this work clinically? Measuring things longitudinally. That sounds like a lot of work. Where would we get someone collecting data longitudinally, which I think if anyone's ever been in cardiology clinic, if you haven't had someone come in and present your blood pressures to you, let me know. I'd be pretty amazed. But what do you tell them, right? We look through it, we're like, yeah, this looks good, this is kind of high. We don't really look at it systematically. More recently, you're probably getting these reports. I'm really worried my Fitbit showed me this thing. What do I do? This is data that's being presented to us. In the cardiology world, we're surrounded by it. Everything we do is sort of collected in data that's hard-coded. It's in reports, it's in the Holter monitors, it's in stress tests, it's in multiple sources, not to mention the electronic health record that everyone has. So we're sort of around all this information, but then so how do we use it? And this is kind of a question. As I started to learn a lot of these, the analytical methods to this, started to ask this question, well, so how does this work in practice? How would I do it? So I went out and bought the one thing that seems to collect, a lot of data longitudinally, the Fitbit. And I've said, let's just see what kind of information I can get. Was it useful at all? And this was my first experience. I bought it, and we went on a ski trip up to Vermont. And, I wore it, so I, was skiing here. Ate a meatball sub, probably shady. I probably should have paid more attention to the hygiene of this restaurant. But if you notice, this is my resting heart rate. I fell asleep here, and as you see, it starts going up, up till about midnight. And at midnight, it's up, I don't have the scale here. It's up about 10 to 15 points. Again, seems like kind of a subtle thing. Obviously, I'm asleep. I didn't feel it. But then at 2 in the morning, I wake up. I'm nauseous. I'm throwing up, like a vagal reaction. So it's captured on here, So, what's interesting about this is not just, that it's that I can link sort of an actual event in my life to biological information, but that if you think, if I were to present this to a physician, do you have time when you're seeing 25 patients to sit down and be like, oh yeah, let's go through all this data? You don't, but each individual does. This is something that I got just from looking at my own information. So it kind of clicked to me, if we had a way to sort of allow patients to look at their own information and then, or maybe filter it, that we could get useful, more clinically relevant information. So I started modeling this with other things. You could actually correlate. I would keep a log, did I exercise that day, and then see, did that affect the calories burned? It's interesting. I'm presenting these as sort of a forecast, but these are correlations, and so you can see these bars are right on top of each other. If I exercised, whether I chose to do that or not, it didn't make a difference in terms of calories, in terms of sleep. I thought this was interesting. I was tracking alcohol for a period and saw that actually it was the opposite. Usually most of us would think the more drinks you have, that your sleep quality is less. It was actually the opposite for me. And then I started to think about, well, what was I doing here? This is the zero. You have the worst quality if I have 0 drinks. And it was, if you're on, as a doctor, when are you not drinking? It's when you're on call. So that's obviously the worst sleep quality as well. So, but again, it kind of took home this idea that if I'm taking orthogonal data sources, if I'm taking a monitor, I'm collecting other information against it, that I can actually start to build, correlations. I can build models and start to learn about sort of these deeper lifestyle issues. So it's great for lifestyle, but what about for disease? Well, cardiac devices provide amazing information for this. This is an actual patient who this is their activity log up here, and this is the amount of atrial fibrillation they're having there. Well, we have this question, what is symptomatic atrial fibrillation? Because, we all know a lot of people don't necessarily feel palpitations as their only symptom, but they may have limitations in activity. And you can actually use this data quantitatively. You can say, are you less active on days with AFib? Are you more active, more likely to trigger AFib if you're more, after a day of heavy activity? Are there trends? In this patient, we saw that as the activity went down, as the AFib was going up, activity is going down. Again, it's a correlation, but it's the information that's basically otherwise just winding up on the floor or in some chart, hidden in the medical record. What's even more interesting is you can take longitudinal data and you can always build a forecast. And so I can say, if I don't do anything, how much AFib is this patient going to have? And I can build these are different sort of confidence intervals. So then if I do a PVI and I see that actually, you've decreased the AFib amount by, some significant proportion outside the confidence interval, we've just applied a quantitative measure to a treatment that normally they would come back to clinic and be like, oh, how's it going? Pretty good. Exercise, it's what was previously qualitative. So, again, as I was sort of, going through this, I start to realize, well, this can be applied in a lot of different realms. And I think that, it's interesting because one of the biggest insights I had into this was the idea that it's not always the monitor that the data you're collecting is not always going to be applicable to the condition you think that it's most useful for. To give you an example, like if you're collecting EKG data from an Apple Watch, we were all interested, like linking to arrhythmias or things like that. But there's actually a lot of biological information that you might get by tracking heart rate. They've started to see this with some of the continuous glucose monitors, where people's glucose fluctuations are reflecting systemic illness, not necessarily a diabetic problem. So I thought about, well, what are some general problems? Like, how would this work, like, if I was to try to apply this prospectively? And so I picked out, well, it's got to be a sort of recurrent phenotype. So I'll talk to you in a minute about which types of conditions it would work for. I thought of, like, what would be, what's one of the most painful things we have to take care of? It's recurrent vasovagal syncope, right? Not fun to, like, see patients with this problem because, frankly, we don't have a good answer for them. It's sort of like this trial and error. They come in, we say, well, try lying down or try some compression stockings or try to stay hydrated or some salt pills or Midodrine or Florinef, or maybe we'll just put a pacemaker in, and come back in 6 months and we'll sort of see how you're doing. And a lot of times it's like, when they come back, it's like, did you find parking easily? Because if you did, then you're pretty happy. Or if, the appointment got bumped 3 times, now you're unhappy even though you don't have any vasovagal syncope. So it's a qualitative approach. But what happens if we quantify that? So what if we take our patients and we have them track over a 6-month period? Well, how often are you having vasovagal events? What's the plot of that? What's the probability? And then we can take a monitor. I include the Fitbit. I'll show you in a minute. We can do this with a lot of types of data streams, which tracks a number of. Even a Fitbit gives you activities. It gives you exercise. It gives you sleep. It gives you heart rate. And so we can take those and plot them together, and we can run correlations. And because you're doing this over time, you can correlate things in both directions. So we can say, well, is it just that are you not sleeping because you're having vasovagal episodes, or is it related to not having sleep before? So for in this patient, sleep the day before is negatively correlated with probability of a vasovagal event. We also can pick out trends. We can pick out cycles. So for example, for this patient, we might come back and say, well, it looks like the sleep the night before is inversely associated with your risk of having vasovagal syncope. It seems like you tend to have these episodes the next day. And we also couldn't help but notice, but there's a 21-day cycle to your sleep patterns. Is there something going on with that? And the patient says, well, actually, every 3 weeks I have to organize my daughter's yearbook committee, and I usually wake up earlier for those weeks. And I say, well, okay, and this is, in a minute, we try an intervention. Well, why don't you try going to bed an hour earlier the weeks of those yearbook committees? We'll collect some data, and we'll see where we're at, right? And they say, okay. And the whole point here is now, again, we're not coming back with a qualitative assessment. We have actual data, and they're coming back, and we're seeing that the trend is gone now, that this is working. This person's going, they're not having the amount of variance in their sleep. The number of events is less. Again, how often do we really track, the numbers afterwards? I think you think of like blood pressure. We'll take one change in medication, we check them in clinic the next day one time, and then we make an assessment based on that, on how their blood pressure is doing. Well, we can get, if we're collecting data longitudinally, we can, track these trends. And of course, ideally the patients will be happier. This is only the beginning. I mean, I'm sort of using sort of toy examples. But the reality is data is everywhere. It's not just monitors. It's on your smartphones. It's on social media. We can mine social media data for information. Internet browser records. I've told everyone about this book, Everybody Lies. It's great. It's about Google trend searches that, people who post on their Instagram, I love my husband, and then are going home and searching for divorce attorneys on, Google later. There's all kinds of important information that's available on internet browser records. Shopping and loyalty cards. You can use electronic health record data, genetic data, biomarkers. There's all kinds of information we can get on people that's actually digital now. So it's literally a matter of moving files over to analyze. The computers are better. Most people are familiar with this idea that there's more processing power in your smartphone than what put a man on the moon. But it's not just that. Storage is cheap. Terabytes of data can be stored for pennies now. Processors are faster. We're using graphic processors. And again, everything can be done in the cloud. I'm not going to talk about it today, but there's stuff we're doing here where we can literally take an entire electronic health record and perform an analysis on the same setting that previously would have had to transfer this data or figure out how are we going to send this in some kind of secure file, which if it's like gigabytes or terabytes can be take forever to send that across. And then the analytical approaches, which are really what I think is the most exciting, are really, really changing. I think people are recognizing the role of Bayesian statistics and how much power there is in putting a prior on data before you start to collect it, and how that can affect, really bring practical thinking to a statistical approach. There's neural networks. This is the stuff that's, image recognition, recurrent neural networks that are being applied to voice recognition. Google DeepMind, they do reinforcement learning. I don't know if people have followed some of the, AlphaGo, or there's basically computer models that are beating humans at games of chess and Go and all the Atari games. This is this was a program that was basically trained on paintings of Van Gogh, and then fed this picture and created a Van Gogh painting from that. So these are analytical approaches that, statisticians will say have been around for a while, but we're really putting into use all around us today. This is not a really complicated process. Basically, how it works is, you pick out whatever your outcome that you're interested in. It has to be quantified, and you just measure it. And you measure it over time, and you can build statistical models for it. Trends, means. And then you just start collecting other data streams, other X's that you think could be related. You find the ones that are correlated, and then you go and intervene. You basically say, well, we saw that, the sleep the night before seemed like it was correlated with the amount of, vasovagal events. Well, let's change that, and we'll see. And the beauty of doing longitudinal data is I can create a forecast. I can tell you, well, if we didn't do anything, this is what we would expect this would look like. And if you collect enough data, these can be pretty accurate. Well, now with our intervention, we're up here. See, we've made a difference. We're quantifying a process that was previously qualitative at best. And as I mentioned, you can do this with all data streams. It's not like I have to go pick out Fitbit, and this week we're going to analyze Fitbit. I can collect anything that's being collected on you over a period of time and run these models. I mean, if you don't work in this world, it sounds like it's, oh, that's crazy, but that's what we do in a genetic model. We run, 6 million linear regressions is how we look for, in a GWAS. So this is the computer. We're already, primed to do this. It's just a matter of getting those data streams together. The way I think the power to me of this, and why I think it's really interesting for science, is that you can take this, this process that's happening, this kind of N of one individual level, and you can start to aggregate it. And that's useful, one, because you can start to analyze patterns in people. You can find clusters of people that have similar responses to a medication. You can also do something that's important where you can take data that's collected on one type of person and use that as a prior on another. That's pretty powerful, because that's actually what that means you can do is I can build a model and then take some new person who I didn't have a chance to collect all this information on and start to form some kind of pretest probabilities around what might work for them. Once you take this up to the higher level, then we can start linking these things to like translational omic types of, are there biomarkers associated with certain responses? Are there comparative effectiveness? Do certain people tend to respond certain ways? Are there certain treatments that are just ineffective in certain people? And then, of course, all the automation, which I wouldn't go into, but there's a whole way to automate this entire process so that a patient can do all of this on their own with just a simple app. But we're not there yet. As I said, this is sort of skating to where the puck, I think, will be. And there's a couple of big issues that need to be solved. I've sort of, this is basically our process here, where we're collecting data from the patient, analyzing it, returning the results, and then the patient and the provider are sort of discussing how to use that information. There's statistical issues. We'll talk about in a minute. Some of this, the statistics are not necessarily straightforward. It's certainly not something in the biomedical world that we're comfortable with some of the problems. Information technology issues, and there's clinical issues. Statistically speaking, so how do we determine statistical significance? This is something that came up in genetics when we first came out. Well, we're doing, a comparison. Do we do a Bonferroni correction where you just adjust for the amount of comparisons you're making? Well, initially they thought that's probably going to be too stringent, and then later on we thought, well, maybe that's just about right. Well, how does that work here if we're using multiple data streams? We're testing multiple different hypotheses or multiple different models. We haven't worked that out yet. How do we determine power? How do we know that there's not a correlation here versus, well, we just need to collect more, and then that'll tell us if we if there's a correlation there or if it's just that we don't have enough information. Confounding bias, sort of Epi 101. You need experts to tell you this. I mean, we can collect all these data streams, but if it turns out that we're just collecting a confounder or something that's irrelevant, then that's not going to be useful clinically. How does that work when you're collecting large longitudinal data streams? Hasn't been worked out well. There's computational, I think of as like data issues. So like, where's the data going to be stored? How do we access that in a streamlined process? As I mentioned, it's easy to move this data around once it's in the cloud, but how do you get it up there? How do you protect privacy? Once it's in one place, then a hacker could, in theory, come along and get all of your information. Now we're getting pretty granular, so it wouldn't be hard to tell who you were from it. How do we get the results to patients, providers effectively? I think this is a huge problem, and I think we're already kind of dealing with this in terms of like applying predictive models. Unfortunately, a lot of these things are just going to have to go through Epic, through the EHR, because if you're seeing 25 patients in clinic, you're not going to have time to go log into the browser and pull up the European Society site and try to enter all this data in to get someone's risk prediction model score. And that's for one problem. I mean, if you're doing it at this level, that's just infeasible. So getting these things streamlined, it's a huge data issue that we're still sort of working through. And then there's the clinical issues. What kinds of questions can this answer? It's not for everything, and certainly not right now. It's not going to be able to predict stroke, because how many people have multiple strokes in a lifetime? MIs, it's at least in the early phases, I think it's going to be mostly for things that are recurrent problems, things that we can, build a correlative model where you have enough observations or enough data points to build the model. What's the process for determining clinical validity? How do we incentivize patients? And how do we educate providers? How do we, to go to the second point, we don't do this very well. I mean, this is sort of like the "are we doing a good job" types of studies that I think that come out, poorly designed, and then everyone gets upset and then moves on. but there's not really a good system for, again, this is N of 1 studies, so you're not going to publish a paper on I predicted Karen's headaches. You need, we're sort of doing meta types of research, and I don't think we have a good way of determining an entire process, at least in the present approaches. So what are we doing here? I kind of described it as kind of a 3-pronged approach. So for the analysis, we've developed this individualized data analysis organization. The technology, we started to develop a couple of apps, sort of getting into that space and learning. And the clinical challenges, I think we're envisioning kind of an individualized medicine and monitors clinic, although I will tell you it's sort of the least developed of all of these resources. So the IDAO, this is a group we formed probably about a year and a half ago or so. It's a pretty wide variety of people. It's clinician scientists, data scientists, statisticians, information technology experts. We have some physical activity experts that come. And we basically just discuss the strategies, approaches for these types of analyses. We meet, I think we took a break for the summer, but we meet roughly once a month. As I mentioned, this is our website. If I have an email, so if you want to email that box, you can email me, obviously. I started a Twitter account. I'm still kind of figuring out how that works or what to post for this. And we actually have a meeting next Tuesday, so if anyone's interested and wants to come check it out, let me know. I can give you all the details. A couple of the apps we started to build, this actually started as one app and then realized that it was easier to do as two. This is one, and I didn't choose it. It turns out that free domains are not exactly easy to find on the internet, so we ended up with Udatalyze, so I apologize for the name. But if you have a Fitbit, I would check this out, because it's basically what it is. It's sort of an individualized Fitbit monitor. It's web-based, so basically the way it works is you go and log in, you create kind of a username, and then it takes you to the Fitbit site where you authorize that data to be pulled into our app. And it'll run a number of different analyses. This is just sort of, as I was saying, can identify the weekly patterns to, steps. If you want to do an intervention, said I started some weight loss program on this date, it'll tell you whether you've made a significant difference since then. One of my friends is the programmer behind this. He's taking it in the direction of starting, there's messaging now, and I'm not sure why that's going to help, but I'm really looking for feedback, especially on the analysis, because that's what I'm doing with this. Because we don't necessarily know what types of useful analysis you can do. All I can tell you is we can do anything you want if you just tell me. So the other one we're doing is basically it's again these names, the PM App Lite, which I think is soon to be called the IM Tracker. This is basically kind of a customized, symptom entry program where you basically, you get to choose whatever that symptom is, as well as, a couple of yes/no risk factors, as well as whether you're doing an intervention. You plug them in, it sort of prompts you. So you can there's two options. You can either plug it in just the days you're having a symptom, so it'll build kind of a statistical model around symptoms. Or if you have a daily entry, it'll remind you every day at a certain time to enter data and run correlations between variables, giving you sort of some feedback on what risk factor, what types of factors could be related to a given outcome, for each person. This is edge-based, so we're not sending this. None of this data actually comes to a central location. It's all just on a person's phone. So if they can choose to share with someone, they can. If not, it's it's sort of the privacy of their own their own phone. So. This is actually, we just got our approved yesterday for our pilot study. It's starting, I think, next month. Again, if you're interested, if you want to be a beta tester, let me know. If you have an iPhone, I'm always looking for people, feedback. If a developer I built the first version. He's looking to make it a little more user-friendly. And then the clinic, as I mentioned, this is sort of kind of more in the pre-contemplative stage, but I think we're envisioning kind of a one-on-one setting where you're bringing in kind of almost like a data analyst into the clinic with the provider and saying, what kind of information are we collecting? What kinds of questions can we answer? I think we'd like to include things like genetic data and go into this, but certainly you can use polygenic risk scores or things like that as priors for building some of these models. I think we're planning this, a year or two out, but I'm still in the early stages. So to summarize, the era of quantitative medicine is here. Individualized approaches using longitudinal data, I think, are where, at least in my opinion, the direction we need to go. There's untapped power for clinical inference. There's a number of efforts that certainly our group are doing on campus to make these, put these into action. Need help, always need feedback, especially on the clinical side. I think that clinical input, especially as you move a statistical method closer to the population, it's more and more important that you're getting feedback about what's clinically relevant. So I'm always looking for help. And that's basically it. This is our group, the people who've been coming to some of the different meetings. I think Kathleen, Michael, and Sarah are with Compass. I have a couple collaborators up in Boulder